Okay, good evening and welcome to yet another episode of Arthroplasty Conclave. And without wasting any time, I will hand it over to Dr. Kiran Karat, the convener of the meeting. Over to you, sir.
Thank you very much, Ashok. It gives me great pleasure to welcome you all for the fourth webinar in our hip replacement conclave series. The foundation has been nicely laid in the first three webinars, which will bring us to discuss and understand two key topics which have a direct bearing, and I intend the pun, on the longevity of the hip replacement: bearings and trunnion. Most of us started hip replacement with 22.25 heads and gradually graduate on to 28 millimeter heads and beyond as newer designs came in. Our generation is lucky to have highly cross-linked polyethylene, which has been around since 1998 and has shown better wear characteristics, and that has to be balanced with ductility and fracture resistance. However, some issues are unresolved, which are in vivo oxidation and rim fracture. We also have ceramics, which have been around since 1970, and we will know more about it in Dr. Narinder Kumar's talk. We are also a lucky generation to have modularity in primary hip replacement systems, so we can recreate good biomechanics of the hip. However, the threat of crevice corrosion is there at the junction of modularity between two dissimilar surfaces, and this type of corrosion is dangerous because it continues even without mechanical loading. Dr. Martin will give us more insights into Trunnionosis. It's really my privilege on behalf of Dr. Surendra Patil and Ashok Sham and my panelists to welcome guest speaker Dr. Martin Zimmerman, who is an authority on all research pertaining to tribology, and he will give us his insights and implications. I thank Mahesh Kulkarni for his help. I thank my panelists, Dr. Vikas from the Air Force and representing the Indian Armed Forces in orthopedics, and also Dr. Narinder Kumar, who is Director and Chief of Joint Replacement and Orthopedics in Medanta, Lucknow. So I hand over the screen to Dr. Narinder Kumar to talk to us on bearings. Thank you very much.
Thank you, Kiran. Without much ado, I think let's get on with the job at hand because time is at a premium and we don't want Martin to sleep too late. He's, I think, a couple of hours ahead of us. And as you already said, the foundation has been already laid, and orthopedic surgeons actually hate a lot of theoretical stuff, and bearing surfaces is actually something which you choose based on your theoretical knowledge. And let's see how much we can make it more lucid and interesting to the orthopedic surgeons today. And as highlighted a lot of times in the previous talks, THR is the operation of the century. Learman said it in Lancet in 2007, and everyone has been repeating it for the last dozen years. Okay? It is not just one of the most successful surgeries, it is also one of the most constantly evolving in terms of technological innovations. But with all that innovation, is the survivorship of THR really what it is supposed to be? Really what we want it to be? But 25-year-old pooled survival data of hip replacements from case series and joint replacement registries was published in Lancet last year. And it was something which I got surprised with. Only 77% survival in case series, which is mostly from the designer, designer centers like Exeter, Wrightington. And from joint replacement registries, we had only a survivorship of 57.9%. That was a major surprise. I thought the survivorship would be better. But then that's why made me explore a little more. Why were the hips failing? That is why, because the younger patients were getting THAs. Nordic registry showed me this data of actually patients younger than 21 years getting hip arthroplasty done. That's fairly rare in our practice. I probably have done one or two less than 21 years, and their survival rate at A 21-year-old person gets a THA and survival rate is 86%. So 14% are going to get a revision at 30 years of age. That's a lot. And the aseptic loosening was the main cause of revision. So we need to find ways to reduce that aseptic loosening rates. I thought, let's go a little older. Patients younger than 55 years, still young. Another systematic review published last year. 5-year survivals at 98.7, 10-year survivals at 94.6. And then that's the time the data started going wonky. At 10 to 14 years, 27 to 99.5%. That is center variation, a huge variation. At 15 to 19, 59 to 84%. At 20 to 24 years, 70 to 77%. And at 25 years plus, 60% survival. Now, younger patients are suffering quite a lot. And where are these hips failing? One, the failure of fixation. The last few talks have focused on the fixation methods, and we know how to improve it and should not be failing anymore, hopefully. And secondly, they're failing due to wear from the bearing surfaces. Wear could be from poly, could be ceramic, could be metals, could be. So what is this bearing surface which we're talking about, which is wearing out? It's basically an area of contact between two objects. If they have a macro motion between them, that is usually the primary bearing surface, what we are familiar with, the acetabular and the femoral, acetabular component, the femoral head. But there are secondary bearing surfaces like trunnion and the taper junction on the acetabular side also. I hope Martin will be telling us more about the secondary bearing surfaces. I'll stick to the primary bearing surface, which is the acetabulum and the femoral head. And what is this wear from the happening from the bearing surface? It is basically material being removed from opposing and moving surfaces which are under applied load as well. What are the various mechanisms? Abrasive wear, adhesive wear, fatigue wear, third body wear. I'll not go into the too many details of it, but we must remember that probably adhesive wear is something which we must focus on. And in the long term, the fatigue wear. Third body wear is something which we must focus on during revisions. We must not leave any loose cement pieces, any bone particles, even during primary arthroplasty. One needs to be surgically very meticulous. Any small bone piece left in the joint space will lead to a catastrophic wear because of third body wear. So what is this effect of wear particles? Mechanical, I just spoke about, like in third body wear. The biological is that it could be direct cytotoxicity. There could be immunological response. Immunological response is what leads to actually the aseptic loosening. And the various metal ions can lead to carcinogenicity or a systemic toxicity. The wear particles predominantly have been studied from polyethylene. They induce various kinds of response from our immune cells. If they are less than 150 nanometer, they will be pinocytose. 150 nanometer to 10 micron, phagocytosis, or more than 20 micron, giant cell response. Now, 150 nanometer to 10 micron is something which we would like to focus on because those are the phagocytosis leading to the aseptic loosening. They have complex underlying mechanisms involving various cytokines, chemokines. I would not go into the details of it, otherwise we'd have a separate lecture focused on just the chemical pathways leading to osteolysis. But then we know that wear particles are the problem. How to tackle them? We can reduce the wear by bearing surface modification because prevention is better than cure. Or we can modify the response to wear particles, which is the immune response can be modulated. We can use rankle inhibitors, we can use bisphosphonates. There are a lot of drugs which are coming up on that, but then that's for another day. So we want to reduce the wear, so we must have an ideal bearing surface, which should have a low coefficient of friction, a small volume of wear particle generation, low tissue reaction to the wear particles, high resistance to third body wear, and enough deformation permitted in the articular surface to permit the fluid film lubrication during the stance phase. Well, fluid film lubrication is another something which engineering people really love to describe, and we are not really familiar with it so much, but which is the ideal one, the bearing surface. Now that I've given you the description of it, human articular cartilage remains the best bearing surface available in engineering terms because it has all those features which I just described: low coefficient of friction, no wear particle generation, no tissue reaction, and no third body wear and enough deformation. Compared to a cartilage, most of the man-made bearing surfaces have hundreds of times of higher friction and wear rates. The options available to us are, number one, the gold standard, which is polyethylene, which could be the polyethylene insert in a uncemented component, or a cemented acetabulate cup. And on the femoral side, it is the cobalt chrome alloys, which remain the gold standard. But the new gold standard, probably Martin will tell us. Now, how to modify this? We can modify the poly, or we can just replace the poly. And there are multiple options on the femoral head side as well. As long as we bow our heads to the holy grail of zero or minimal friction, a low surface wear, and minimal, absolutely minimal inflammatory response to those wear particles which are generated. Chanle taught us how to reduce the wear in the small head, and of course he is the one who brought polyethylene into the practice of orthopedics. But we must remember, it is not any poly which can be used. It is the ultra high molecular weight polyethylene which can be used in the orthopedic practice, and it remains the mainstay of joint replacer over the last half of a century. The results in elderly have been good, but as I highlighted earlier, it's the young patients which remain the challenge, where we need to improve the poly for those young patients. The industry has added newer manufacturing processes in the terms of new sterilization techniques, new manufacturing techniques, that is direct compression molding, which is a little more expensive technique, but it has much lesser wear rates than the more popular RAM extrusion. RAM extrusion allows the industry to manufacture at a much larger scale, but at a lower cost. Obviously, they prefer RAM extrusion, but if we had a choice, I would always use a direct compression molded polyethylene. And there have been advances in polymer chemistry, the cross-linking, which is what everyone is talking about. Cross-linking, first generation, second generation, third generation, and whatnot. And we'll see what all that cross-linking is all about after we know what the sterilization does to the poly. The sterilization, number one, if we do, again, what the industry says, bulk sterilization by radiation, that leads to oxidation of the poly. That oxidation is obviously going to reduce the mechanical properties of the poly, which is in form of decrease in molecular weight, loss of ductility, decrease in strength, and we have disastrous, breakages of poly, both in the knees and in the hips. So how to improve it? Well, the same industry gave us improvement in the poly in form of radiation sterilization only, but not in presence of air, but in vacuum or in presence of an inert gas. Or the other method of gas sterilization, which could be ethylene oxide, or plasma sterilization, which these gas sterilization methods do not cause oxidation of the poly, which is basically the oxidation remains the main enemy of the poly. And once you test these things for wear, the gamma irradiated poly in a vacuum environment and with use of barrier packaging remains the one which has the least wear rates, and of course gamma irradiated poly in air has the maximum wear rates. I will not bother you with the technical details of the cross-linking process, except that it's the radiation, various doses of radiation which cause the cross-linking, and simulator studies have borne out that they have definitely increased the wear resistance and decreased the wear particles. The various first generation cross-linking and then second generation cross-linking happened by addition of the annealing process, which is multiple cycles of irradiation followed by sub-melting point annealing. This is how a longevity cross-link poly from Zimmer is manufactured. I would not bother you with the technical details of it, but the final one is, during this process, you can add free radical scavengers. Vitamin E poly, the yellow colored poly which is commercially available, is the latest generation of poly which is now available with us. This cross-link poly basically removes any, decreases the in vivo oxidation. So while having similar wear characteristics as a cross-link poly, it has better fatigue resistance in the long term. That is what theory says. We would know from the registry data in probably a decade or so, because this poly hasn't been there long enough. The effects of cross-linking, as I already said, it improves the adhesive and abrasive wear, which is the main thing, main wear in hip replacement, but also it comes at a cost. of decreased ductility, lesser resistance to fatigue failure, and makes it more brittle. But hopefully, vitamin E addition will take care of that part. Commercially available options, there are multiple of them. I'll not go. I've just named a few of them. There are probably a dozen more available from various companies. Coming to, okay, all these are the options, but do they work? Well, there are so many studies which have now documented that there is significant reduction of wear as well as, which is volumetric wear as well as the linear wear in cross-linked polyethylene. This is just one of them. There are so many of the long list of them. But does this wear lead to decreased osteolysis also? Yes, it does. We have 10-year follow-ups, we have 15 years and 20. Now 20-year follow-ups also close to being available in terms of which shows that osteolysis is almost nil at 10 years in this study, but longer term studies have shown that the osteolysis is much, much lesser. So, is it compatible with large diameter heads? That is where a major contentious issue is with, orthopedic surgeons get greedy. Once we have the lesser wear, we want to put a larger head because larger head is going to reduce the dislocation rates and increase the range of motion. But then that comes at a cost of higher poly wear. So with fatigue setting in at a longer time, rim cracking and liner failure can happen with conventional poly as well as with cross-linked poly if thickness is less than 5 mm. Although there is a study which compared a 3.8 mm cross-linked poly with that of 5.8 mm and found no difference. But most of us, most investigators, most surgeons would not like to use a thin establer liner less than 5 mm, definitely, because they are going to lead to early failure. There are cases which have been reported. So, but in the long term, we know that cross-linking has led to favorable as well as unfavorable changes, but so far clinical outcomes have been favorable, and that brings us to the metal-on-metal bearing, which is probably something which has been in clinical use much longer than any other bearing surface, much before the poly came along. Mecki Ferrar used it and so many others used it. And it was a commonly used option till the last decade, and because of its apparent advantage of great resistance to wear. But it also had a huge problem called alveolar lesion, which we now know over the last decade. This alveolar lesion, I will not go into details of it, but National Joint Registry of England as well as the Australian Joint Registry came out with their data, and they found a huge risk of revision coming over at 5 years, 6 years, 7 years, 8 years, catastrophic failures. So the rate of metal-on-metal total hip replacement obviously then dropped after that, and with the registry recommendation that these should not be implanted. And obviously we know that DePuy and a lot of other companies are still paying for it even after a decade since they stopped implanting these because of the lot of litigation issues. So, which brings us to the ceramic on ceramic bearings. Well, surface finish of ceramics, we know that is much smoother than the metal implants. They're harder than metal, they're more resistant to scratching and third body wear, and the linear rate of ceramic on ceramic is almost zero. So they should be actually surviving forever, but they do not, because they do have their issues, which those issues were resolved from first generation to second to third to fourth generation now for the last 20 years. The fourth generation ceramic is what we call as delta ceramic now. These improvements are fairly technical things, which somebody wants to use, they can ask for my presentation, I can send it over happily. But one must understand the tribology of ceramic on ceramic, that the smaller grains have led to a lower surface roughness, leading to reduced friction. High hardness of this delta ceramic has led to low wear rates, and high wettability of the same ceramic has led to fluid film lubrication. In fact, ceramic on ceramic is the only bearing combination which we have in which fluid film lubrication happens. Most of them is either boundary lubrication or so again, as we explored on the poly, is there evidence on ceramic on ceramic? Is it more resistant to wear? Has it reduced osteolysis? Are there any unique complications specific to ceramics? Is the longevity better? Let's see if we can answer these questions. Well, more resistant to wear? Definitely, yes. There are various RCTs which say that. Now, when we go to histopathological analysis of the debris, the reaction to wear debris of ceramic is fibrocytic, no giant cells, hardly any macrophages. So there's not much in the periprosthetic tissue, so there's hardly any aseptic loosening. So ceramic on ceramic remains the only bearing that has long-term survival without adverse reaction to wear debris. But there are unique complications to the ceramics, where because ceramic is brittle material, it leads to those thin liners can fracture, especially while being inserted, because the taper junctions are still a challenge, which probably Martin will tell us about what is the taper junction challenge about the liners. And old generation, the first and second generation ceramic on ceramics had a fracture rate as high as 20%, which led to them falling into disrepute. But with the Delta ceramic, that has less, the fracture rate has come down to less than 0.1%, which is absolutely acceptable. Squeaking remains, the noisy hips remain a problem. They became very popular courtesy of the striker hips. But then as we learned more about these squeaky hips, we realized that the squeaking was not because of any inherent issue in the ceramics. It was because of a malpositioned component. Hard-on-hard bearing are very high-demand surgeries. All the principles which were outlined in the planning of the surgery and in the cemented and uncemented components which were highlighted by the previous speakers in the session 1, 2, and 3, they need to be followed very meticulously to have a perfect position of the acetabulum component, as well as a good offset from the femoral side also, to avoid any striped wear which will lead to squeaking of the hips, because that changes a lot of biomechanical conditions there. But then clinically, these have now become fairly rare because we understand it now much, much better. And then ceramics with their only one head size per cup diameter, no lateralized liners, no elevated rims. We have all these options in the poly. They decrease our chances to customize per-operatively. You need to have a perfect pre-op plan and go and implement it there. Because equalizing leg lengths and adjusting the offsets, vertical and horizontal, will become a challenge. If you're using a ceramic liner, we can't use poly for it. Even for stability also, there's no elevated liners available. So that places you at a disadvantage. And then this is something which I've revised for, the liner chipping on insertion. I've had patients coming to me where the index surgeon forgot, or rather ignored, that the liner has been not seated completely. That happens. One, there's a taper junction issue. Secondly, there's a malposition. There's a surgical technique challenge. Or there's a manufacturing issue also, that when we are impacting the liner and the shell expands and the taper junction is not adequate to cater for that expansion. So when the patient starts walking, there is a chipping of the liner of the edge of the liner. This is basically a design related issue, as I said. So, and there are obviously difficulties during revision of a broken ceramic. Whenever we are trying to revise a fractured ceramic, a total synovectomy is needed, and liner exchange usually is not sufficient. We have to revise the cup also, because while we are removing the liner, the shell or the taper junction of the shell may get damaged. So is the longevity better? Well, it is comparable. We will have the data very soon. As of now, the outcomes are comparable to metal on poly or ceramic on poly articulations. Time shall tell, but right now they are going neck to neck with all other bearing surfaces. Which brings us to the ceramic on crosslink poly or ceramic on conventional poly. Most of us are not using conventional poly now anymore, because we know that ceramic on crosslink poly, both the creep and wear rates are significantly better. And this is what most of the studies are also saying. But then the effect of large head size, because this is what most of us try to use. This is showing that 36 mm actually has the accelerated poly wear rate, the higher rate, as compared to 28 and 32 mm. So be careful when you're using large heads in that thin poly liner. And the final option, the oxidized zirconium, the ceramic metal alloy, which is patented by Smith and Nephew, so I will not be encouraging about it too much. But it is metal that can be oxidized, which becomes zirconia on the surface, which is you heat the outer surface, which becomes now the patented name called oxinium, the oxidized zirconium femoral head. It has similar properties like ceramic, low wear properties, but the advantage of the strength of the metal within its core. So becomes less susceptible to the brittle fractures which ceramics were actually susceptible to. So with all these options which are available commercially to us, let's see what do the registries say. The Dutch Arthroplasty Register published in 2018. I was actually surprised. I was expecting that the revision rates would be minimum for either ceramic on ceramic or ceramic on crosslink poly. I was surprised to see actually the oxinium on crosslink poly has the least revision rates. And of course, ceramic on ceramic was one above it. And as expected, metal on conventional poly had the highest revision rate. So this was only the Dutch Arthroplasty. I said, okay, let me explore the Australian registry, Australian New Zealand combined registry, of course, which actually showed the similar trends over a longer term. At 15 years, again, it was ceramicized metal or the oxinium on crosslink poly, which had the least revision rates. Again, now that was a surprise. Metal on crosslink poly and ceramic on crosslink poly, ceramic on crosslink poly was number 2 and number 3 was metal on crosslink poly. So there were no surprises there except that the oxinium on crosslink poly has the least revision rate, lesser than even the ceramic on crosslink poly. So that says something. So having covered all the biomaterials which are available, now what are the alternatives which probably will be available to us in a few years? The polymer composites which have been explored, Cambridge Cup, Mitch Cup, they were explored in the around, I think about 5 years back, but their data says that they have not really worked well, so not being launched commercially. Then various options on the metallic side or the femoral head side also are being explored. Surface texturing, actually we expect in engineering terms, we would expect that surface texturing should lead to higher wear rate, higher friction rate, but it happens other way around because all those dimples, they help out. How? The dimpled femoral head, just like surface texture poly, had lesser maximum contact pressure, lower volumetric wear, 10% lesser wear depth has been documented, and the dimples provide better lubrication and allow capturing of the wear particles out of the fluid film, leading to lesser third-body wear even. The special coatings which are being explored both on the establer side and the femoral head, none of them is commercially launched, but they are there, which are expected to change the lubrication to fluid film lubrication. I hope they work out. Long-term results are not as yet available. Probably it's only animal studies which are going on. Various compliant bearings like polyurethane are being tried. And last but not the least, the Institute of Biomedical Engineering of Leeds is trying tissue scaffolds for transplant after removing their cells. Basically, biomed is now science fiction, which we are talking of. They want 50 active years after 50. Let's see if they're successful. I don't know. And talking of the engineering aspects of bearing surfaces, the kind of research which is required, it requires scientific knowledge in many engineering fields, and all of them coming together to collaborate. They are collaborating, and hopefully we will have something new very soon. So that is what the future was. So now seeing what is available to us, what should we be using in our younger patients specifically? Older patients, everything works well as long as they are working in young. So crosslink poly, probably yes. Ceramics, probably yes. Oxinium, yes. In fact, going by the registry result, that should be the preferred surface on the femoral head side. Special coatings, I would wait for the results. I am not one of the early adopters. I am a little skeptic about in my practice. I want to wait for the registry data results. Peak composites polyurethane, that's just science fiction. Let's see if they survive in the longer term. Coming to the future, one must remember that history of orthopedics has its fair share of disastrous failures of well-meant implant improvements. Because not necessarily all of them were improvements. Not all of them are in vivo successes. So further research remains warranted before we adopt them in clinical practice. And to conclude, the long-term survivorship requires the triad to be focused on: the patient factors, the surgeon factors, the implant factors, and this is what we are exploring in all these webinars. And bearing surface options just form a small part of the implant factors. Hopefully, we will choose wisely and depending on our patients. Thank you.
Excellent, Narinder. Thank you very much for a very comprehensive talk, and that has set the stage for Martin Zimmerman to talk to us about Trunnionosis, and then we can have a combined discussion and also welcome Martin's views on bearing surfaces. So thanks for keeping in time, and thanks for a wonderful exposition on bearing surfaces, which will help us choose wisely for our patients. Thank you very much. Dr. Martin, can you please share your screen?
Yes.
Thank you. Dr. Martin is a PhD in material sciences and has a long association of more than 2 decades in orthopedics. So thanks for joining us.
Okay, thank you. Good evening to everyone, and best regards from the Philippines. As you may know, it's 2.5 hours more than you, but I'm still okay. No problem about that. No worries. So first of all, I would like to thank Dr. Kiran and his team for giving me the opportunity to speak about Trunnionosis in total hip arthroplasty, and with the question, are ceramic heads the answer? First of all, as you all may know, I have a disclaimer since I am a consultant for Ceramtech, which is the manufacturer of the BIOLOX Delta ceramic. Let me start with what you call fretting corrosion. I don't want to go too much in detail of the mechanism. I think you heard a lot of publications and presentations about that. But let me speak about 2 perspectives what can occur if you have fretting corrosion in the hip system. First of all, we have what you call the technical perspective. You can imagine that the damage of the taper is so strong that you can have a fracture of the taper, as you can see here on the right-hand side on top. But this is actually very seldom. More critical is what we call the biological perspective, with all the effects associated with the corrosion products of the organism. As also mentioned before by Dr. Narinder, that we have metallic wear debris produced, corrosion products, ions, and all this causes the problematic of metallosis and ALTR. So that's a serious issue that we try to avoid. If you look in the recent literature about the occurrence of fretting corrosion in vivo, you see that following the different publications, we can have up to 4.2% of revision with metal on polyethylene articulation, specifically due to fretting and corrosion. It was a much higher rate with metal on metal, due also to the fact that the metal on metal create all these ion aspects and coming in their interaction between the head, femoral ball head, and the taper of the stem. So we can ask us 3 questions. What about the qualitative corrosion on the stems? Are they the same if you have a stem using a ceramic ball head versus a metallic head? What about the quantitative corrosion? From where exactly comes all this material loss? Is it coming from the taper of the ball heads or the taper of the stem? Especially knowing that, as mentioned previously, the hardness of a ceramic is much higher as cobalt chrome, so maybe we can expect to have more fretting and corrosion than cobalt chrome. And finally, what about the issue for a sleeve ceramic, which I would like to come a bit more in detail at the end of my presentation. But let me start with the so-called qualitative aspect. For that, we concentrate on one of the first publications by Steve Court, specifically on the retrieved analysis of 50 ceramic ball heads and 50 metallic ball heads in a matched pair patient. We exclude the metal, and we wanted to see exactly what happened in this situation. So they use what we call the IGS score, which is a qualitative scoring system that you can see on the right-hand side. Notice 1 to 4, 1 being no fretting corrosion, 2 mild fretting corrosion, 3 moderate, and 4 severe. And this is now represented on this graphic with the axis 1 to 4. And what you can see is two groups. On the pink side is the retrieved found with the ceramic ball heads, and the blue side with the cobalt chrome ball heads. So if you look just in the average, you can see that the blue are higher in average than the pink one. You see qualitatively there was more fretting corrosion observed by using metallic head than ceramic heads. If you look now more specifically on the material of the stems, which is shown here, if you use what we call the conventional titanium aluminum material with vanadium, we have much less fretting corrosion than with the TMZ depth, which is also called the beta titanium, which is a more flexible alloy and was creating a lot of fretting corrosion. There is actually also another study by the group of TAN, which was also analyzing retrievals. There were two groups in this study. First of all, ceramic versus cobalt chrome, and oxidized zirconium versus cobalt chrome. The intent of this study was to study the effect of the taper design, specifically the size of the taper, the depth of the trunnion, the implantation time on the fretting corrosion issue. So they used for their analysis 52 ceramic head versus 52 cobalt chrome heads, which is about the same as the study of Steve Kurtz. And also with the group of oxidized zirconium, there were 8 oxidized zirconium versus 8 cobalt chrome. I should say from a statistical relevance, is a bit too low to make a very secure conclusions on the study. Anyway, they came to the conclusion that the taper design, specifically the taper size and the implantation time, has a significant effect on the tribocorrosion. That means the longer you have the hip in vivo, the higher the risk to have fretting corrosion, and the smaller the taper size, the higher the risk because you have a higher torque acting on the taper of the stem coming from the ball heads. For the first group, they found clearly there was a significant lower median fretting and corrosion score on the ceramic heads than cobalt chrome. In the second group, between the zirconium and cobalt chrome, there's still no differences between the two groups. And finally, they came to the conclusion that the using ceramic heads may offer advantages in terms of fretting and corrosion. Let me go now to the second aspect. What about the quantitative corrosion? From where does it come? Again, we refer to the study of Steve Kurtz, the same study as was done before with the 50 heads and the 50 heads for ceramic and 50 cobalt chrome heads. And now they analyze more in detail the loss of material coming now either on the left-hand side from the taper of the stem, or as you can see on the right-hand side from the taper of the head. It was clear to see on this picture that on the right side that most of the material loss come from the ball head, about 10 times more than the material loss from the taper of the stem. And remember, if you speak about ball heads and specifically about cobalt chrome ball heads, most of the metal that you use, the ions, is cobalt and chrome, and that is exactly all the problematic that you observe with metal and metal. If you look on the left-hand side with the loss of the material from the taper of the stem, we see with the pink version a slightly bit less loss of the material compared to the cobalt chrome. If you look now, again, based on the taper of the head, on the pink side, there is absolutely no loss of material coming from the ceramic ball heads. What about the fretting corrosion if you speak about sleeve ceramic? So sleeve ceramic, just to make it clear, if you see the picture on the top right side of the slide, this is a ceramic system which has a sleeve which is principally developed for the revision system, and I will go a bit more in detail a bit later on that. But as you can imagine, Ceramtech, before launching this product on the market, has done a lot of testing in vitro, specifically also about the fretting and corrosion. And what we can see with up to 10 million cycles, there was no occurrence of fretting or corrosion, thanks to the fact actually that the sleeves were made in titanium, aluminum, vanadium alloy. There's also a retrieval study going on this aspect and analyzing now an both interface, because by having a sleeve, you have one supplementary interface. You have now an interface between the ball head and the sleeve, and between the sleeve and the stem. And they analyze now the level of fretting corrosion. But they came to the conclusion that in these two only studies that exist up to now about this analysis on the BIOLOX option system, the time of implantation and the number of implants was too short to make a conclusion very clear. But let me show some pictures coming from these retrievals. First of all, some example of fretting corrosion scores from the interface between the stem taper and the inside of the sleeve. So on the left-hand side, one, no fretting corrosion, mild and moderate. That's what they can find. And if you look on the outside of the sleeve, that means now in contact with the ceramic ball head, only 2 levels of fretting corrosion has been observed. No fretting corrosion on the left side and the mild one. Let me go a bit more about the discussion about the BIOLOX option, especially that it will come more and more on the market and also in India. So this is a system of ball heads from sizes 28 millimeter in diameter up to 48 and comes with different sleeve size, S, M, L, XL, in order to adapt the leg lengths of the patient. The only statistic that I can show is based on the February 2017, but more than 500,000 systems has been implanted worldwide up to date. But let me go about this slide, which is the most important to understand exactly the role and the advantage of using this kind of design if you have some problems with the taper. So using BIOLOX option system, we can categorize this in 3 groups. First, during the primary total hip arthroplasty, during the surgery, or during a cup revision, and finally, which is also the reason mainly that has been developed during a fracture of the ceramic. Let me start with the left-hand side. You can imagine that during a primary hip surgery, for any reason, you can have a taper damage occurring with an instrument. And if you have a damage on the surface of the taper, you create locally a kind of scratch. And this is strongly recommended to not use a ceramic ball heads because we know that locally you have an increase of the stress, which can strongly reduce or increase, let's say, the risk of fracture of the ceramic ball head. So this is always recommended to have it in case something like this occurs during the surgery. Now let me look at the second situation, the situation of a cup revision with assumptions that you want to preserve the stem. The stem is nicely fixed, is not loose. And so what you do if you change the ball head, then you have to use a sleeve if you want to use a ceramic ball head. This can occur in a different situation. You can have imagine that you just want to change the neck length of the stem. You want to change the head size, or we want to change from polyethylene insert to ceramic liner, and so on and so forth. For this reason, because you cannot use a normal ceramic ball head on a damaged taper, you need absolutely to use the BIOLOX option system. And finally, if you look on the third situation, in the case of fractures, then you need to change, of course, the ceramic liner. Sometimes also the head can fracture. And in this situation, you need to have a ceramic liner used with the BIOLOX option. But there is some limitation. The sleeve system has some limitation in the case, as you can see in these 3 schematic pictures of the deformation that you can have during on the stem of the taper. If you imagine that you put the sleeve on the taper of the stem and you have a waggling and you feel the impression is not stable, then you also recommend to not use this system and most probably to change the stem. But if it's too difficult to really change the stem, then to use a ball head in metal. Now, the same situation with some pictures in vivo on the left-hand side where the BIOLOX option can be used. You see the taper of the stem is still okay. Here on the right-hand side, the taper has been deformed and is not safe to use the BIOLOX option system. Why and what should be done in case of a fracture of a ceramic and you make an exchange? First of all, you have to perform a thorough debridement, jet lavage, and synectovy, because actually it is impossible to get rid of all these ceramic particles. Most of them you can see, they are large enough. If you do the synectovy, we take a lot away, but there's a lot of microscopic particles which will still remain inside the articulation. That means if you use after a combination of a metallic ball heads against a polyethylene, for instance, with the presence of this ceramic particle, you kind creating a grinding machine and you create really a problem. And I will show you after a lot of publications speaking about that. So the metal head must absolutely not be used when you have replacement after a ceramic fracture. From a tribological point of view, the best situation is to use a ceramic on ceramic, because then this remaining ceramic particle will not affect the articulation and the wear issue. And the second best solution is to have ceramic on high-cross polyethylene. We also have some cases that we can show that the ceramic particle, which still remains in vivo in the articulation, comes embedded in the polyethylene, but does not affect now the scratch surface and the scratch resistance of the ceramic. So again, and that's the most important slide maybe here, speaking about the BIOLOX option after revision of a fracture of a ceramic, never use a metallic ball head as a replacement. There's plenty of publications out there as a literature. Here's some example speaking about this situation that you have to avoid that. If you look just the last one in 2012, there was a single case study. There was a clearly intoxication of the patient up to death due to the fact that the metal on polyethylene was being used after ceramic fracture, and half of the metallic head disappeared and created a big metallosis in the articulation of the patient. So this brings me already to the conclusion of my presentation. You have to remember that fretting corrosion occurs up to 4.2% of all cases of revisions. The ceramic heads can mitigate the damage, and the material loss comes mainly from the stem taper and is independent of the stem material. The material loss from the metal head comes mainly from the taper of the ball head, and that's always cobalt chrome, and the magnitude higher than that from the taper of the stem. So in that conclusion, we believe that ceramic heads are resistant to corrosion. And finally, even the use of ceramic ball heads are reducing the risk of fretting corrosion. This is why, if you look now at the recent literature speaking about the issue of fretting and corrosion, they clearly propose the fact that you have to use ceramic instead of metallic head, even though with metal and polyethylene. And now I'm more than happy to discuss a bit more in detail in taper in general and in tribology and bearing surfaces also. Thank you.
Thank you very much, Martin, for your excellent talk on trunnions and ceramic and the sleeve options which we have. I would also like to know your thoughts on the bearing surfaces and the current state of the art in that. But before that, there is a situation sometimes when there is impingement of the trunnion on the edge of the ceramic cup. And I think one company has developed a sleeve for that rim of the ceramic cup. In your experience, have you any thoughts on that to prevent impingement in the extremes of motion in such a situation?
Yeah, we had these different situations. There was also the development of one company, and it was mentioned also by Dr. Narinder, is the striker. That was why it was also a lot of fretting and corrosion. They are putting on the cup elevated metallic rim to protect the contact. If you have high range of motion, the contact between the neck of the stem and the ceramic. But what occurred, unfortunately, was the discontact between the metal of the rim of the acetabral cup and the neck of the stem created locally fretting corrosion or corrosion. And this particle came inside the articulation of ceramic and ceramic and created more squeaking. So we came out to the conclusion when we spoke about all this issue of squeaking, that having a combination of using this product from Stryker, specifically the Trident cup, and then was very high related. What you speak about is also the idea of having a metallic rim around the ceramic liner, which is from Smith & Nephew. The idea for that initially was developed with the fracture rates from the BIOLOX Forte, the previous generation of the ceramic. And they came to the idea that by having this, you have to see that the metallic rim was compressing the liner of the ceramic, reduce the risk of fracture. It was true by having it with BIOLOX Forte, but since we developed the BIOLOX Delta material, this rim has no use anymore. It's not value. On contrary, it makes you even reduce the potential to have a larger head for a given diameter of the cup. Because now if this rim is about 1 millimeter in thickness, that means 2 millimeters on the diameter. So for a given diameter of the cup, the ball head you can put inside is smaller due to the fact that this metallic rim will take some space. So that's the reason why actually no other company was going this same direction as Smith & Nephew has been done with this design of the rim. But now for the impingement is not, to my opinion, helps a lot.
Thank you very much. I would welcome Narinder, Vikas, to discuss
both the
Martin.
topics were very well discussed by Dr. Narinder and Dr. Martin. So there are a few questions which just came up while the talk was going on. First to Dr. Martin, I just wanted to know your views on the ceramic head size. Like about a decade back, when the cup size would increase, there would be a tendency to use a larger ceramic head, going even up to 44. But gradually, with the trunnion issues coming up, it was understood that any head size which is more than 3 times the taper, that is, if it is a 12-14 taper, anything more than 36 millimeter will have a very long lever arm on the trunnion and increase the trunnionosis. And hence, some surgeons and many of us stopped using the larger head. Even with a 60 cup, we would still use maximum 36. Is this still the philosophy? And this is the reason that the size is limited to 36? What are your views on this ceramic head size? What limits the size?
In general, the idea to have a larger ball head was to reduce the risk of dislocation, which is one of the main reasons of revision of total hip arthroplasty. So the larger the head, the lower the risk of dislocation. That was the idea to have always larger and larger. As you mentioned, unfortunately, at the same time when there was this development to have larger heads, was also the idea to have a smaller stem on one side and smaller taper, which, as you mentioned correctly, increase the risk of fretting corrosion due to the torque. But I think the main reason that the people stays now in limited head size is to the fact that we realize that having a ball head bigger than 36 millimeter does not reduce so much the risk of dislocation. There's a kind of plateau coming, so you don't win too much having that bigger ball head in the size. The advantage by having ceramic on ceramic versus ceramic on polyethylene or metal on polyethylene with a large head is that the wear rate of the ceramic on ceramic is independent of the head size. So the wear rate for 28, 32, 36, or 40, even 44 is the same. So if you want to optimize the situation for your patient, you always try to have the largest ball head as possible to reduce the risk of dislocation. And by having ceramic on ceramic, you don't increase the risk of wear. And now we comes to a kind of compromise, which is the 36 millimeter ball head.
But at the trunnion, the issues remain same between metal and ceramic.
No, as I showed before, the loss of the material, if you analyze, it comes from the taper of the ball head mainly, 10 times more than the taper of the stem. So with ceramic, we didn't see any loss of the material on the ceramic. So even though you have a larger ceramic ball head, you increase the torque, which is true also with metallic ball head. But since there is no loss of material on the side of the ceramic ball head, what you create on the loss of the material on the taper of the stem is not much more higher.
Okay.
The problem was to have a cobalt chrome ball head. The best is to avoid cobalt chrome ball heads. And then to have a larger ball heads, there's different publications. Some publications showing more fretting corrosion with a larger ball heads, and some showing there's no difference. It's independent of the size of the ball head.
So what I understand from your talk and your explanation is that if you're using ceramic, the optimum size is irrespective of the wear. So it is because of the dislocation is optimized at 32 or 36 that you need to stop there. It is not the wear. Wear is not a bother if you go higher in ceramic, whereas it remains when it is metal.
No.
Okay. Good. So other thing I wanted to ask you is, you mentioned about taper sleeves and the use of it both in primary and revision setting. You showed us some images where you showed that you could get your longer leg length and you can adjust using those tapers in primary. You showed us that you could adjust for your offsets. And if I understand correctly, there are some systems like eyeball where you can also correct your versions a bit with the taper, anti-version and retroversion offered by the taper sleeve. There's a company which has that also, eyeball. So, the basic question which I wanted to ask you is, that being so, do you want the taper sleeve material to match the stem material? Because if it is a cemented stem of a cobalt chrome, whereas a titanium uncemented stem, the taper sleeve material, you would like it to match, or it is independent of the material? A simple titanium sleeve will work in both.
Yeah, that's a good question about the material, because there was a lot of issue coming also to the fact that if you are using different kind of materials, you can also have some corrosions coming called galvanic corrosion, specifically if you have a titanium stem and a cobalt chrome head. But the galvanic corrosion, if you really look in the amperage, the rate of corrosion is so low that you will feel something much after the death of the patient. So galvanic corrosion exists, but is not critical in this situation. So mixing a material, having a cobalt chrome head in a titanium stem is not a problem. That's point number one. Now coming to the sleeve that we developed by Ceramtech, we make the right choice to have a titanium sleeve because they are more ductile, they can deform a little bit, and specifically if you have a damaged taper of the stem, independent now of the material, if it's a cobalt chrome stem or titanium stem, by having this sleeve and after the ball head, and important that's to impact to have a very tight connections between them, does not make any critical issue. Important is that you have a tight connection. And the difference of the material is irrelevant, it's not important. What is critical is, as I tried to explain, is if you have a damage of the taper, if you want to keep the stem in situ, and the sleeve on the taper is waggling and not stable, then you will not get this tight fixation, and you may have the risk of fretting corrosion, not because of two different materials, but because there's a micro motion between the taper of the stem and the sleeve, or directly about the ball head. So in general, what I want to say is not the difference of material which is critical. It's critical to have a good and tight fixation. And titanium sleeve, which the fact that it can slightly deform when impact, is much better than if you would have a cobalt chrome sleeve. So summarize, titanium on cobalt chrome stem or on titanium stem works very good in both situations.
Thank you, Martin. That is good clarity on that. But what are the millimeter offsets which you can play around with these sleeves, and how much it compromises the inside of the ceramic head? Suppose I have a patient on table, I've decided to use a 36 millimeter ceramic head. What are the ranges of the sleeve options I've got inside to adjust the offsets?
Mm-hmm. Yeah, in principle, they are the same as on the normal ceramic ball head, the primary. The sleeve step is about 3.5 millimeter between S, M, L, XL. So it's the same. It's the same concept. You just have to see that the ball head, instead of having a 12-14 diameter, having conical design like the primary, is actually a 14-16. No, it says to the north 12 and 4, yeah, 14-16. Okay. No, 16-18, sorry. I arrived. Because the sleeve diameter thickness is 2 millimeters, so we have 4 millimeter more to add. So 12-14 becomes 16-18.
For the inside of the ceramic head.
For the inside of the ceramic head, yeah. The good news is, thanks to the fact that this ceramic BIOLOX Delta material is much more strength than that. This question that, as you mentioned, will be critical for the BIOLOX Forte, because if you go too deep,
it will fracture.
It will fracture because there's not enough space. We saw with the analysis of all the fractures we get with the BIOLOX Forte, the previous generation of the ball heads, that actually the design S stem were the more critical, which goes more deep on the taper, because at the inside the ball head, the distance between the end of the taper and the surface of the ball was too short and very less and very critical. With some cases, fracture rate, maybe Dr. Narinder, I see on your statistics, we said 0.1 to 0.02. We have our statistics which shows that on the liner is 0.02%, and the ball head is 0.0001, so 1 of 100,000. We have worldwide about 50 cases of fracture of the ball heads, and we don't see any relationship between the size of the head from the statistical fracture point of view and the neck length. So for the moment, we cannot say anything about that. We cannot say a delta S is more critical than a delta L taper.
Okay. So you encourage, I mean, surgeons all over the world to use the sleeves along with the ceramic head?
No. For primary situation, no. We use
Only
the
for the
normal,
revision situation.
only for the revision situation if you want to preserve the stem.
Correct.
If you change the stem, then everything comes like a primary situation.
That's true. So that is
my concern is about just to be careful that if you have a damage on the taper of the stem, you cannot use what you call a primary BIOLOX head on it, because you strongly reduce the risk, the resistance of the ceramic. Even though there's one publication in Korea and I think another one in Japan who claim, which is good for us, but we don't like that, who claim that thanks to the new ceramic BIOLOX Delta, you can now use directly a primary
even on a damaged taper.
Even on damaged taper. We do not recommend that. It is true, the strength is much higher than the Forte. You have a much lower risk of fracture, but we cannot recommend that because there is no limitation on what kind of damage is acceptable and what is not. There's one time a damage will be too much and you have a fracture 2 weeks after you revise the patient, and we cannot support that. So that's why we always recommend, in case of revision, if you preserve the stem, to use the sleeve.
Correct. Thank you.
In our country, Dr. Martin, since we still don't have the sleeves, there are times when the taper is not much, the damage is not much. We are using ceramic heads in a revision setting, which I don't know whether you recommend or not, but unfortunately we don't have the taper sleeves as yet. One question I wanted to ask you is your opinion about the various tapers which still exist in the market, the variation in them, the 1214, the V40, the few still are sitting with 911 or the SROM 1113. So these, you have anything to comment on these tapers? Should all become 1214? And do the taper sleeves cater to all these tapers? They have the inner dia to cater to these, the V40 and the 911?
I used to work for Sulzer company who was promoting this 1214 taper in the 80s. The idea was also to develop this 1214 taper with, at that time was called Feldmühle, which is now Ceramtech, and having this structure of these micro grooves on the taper of the stem. And the idea was the following, that these grooves, if you put a ceramic head, deforms plastically because it's mainly done on uncemented stems or titanium alloy, which guarantees a tight fixation between ceramic. It does also guarantee a tight fixation between a cobalt chrome. So I was very strongly in favor to have using this kind of design, which is also from a manufacturing point of view, a huge advantage, because you can have some, let's say, less need to be very precise in the manufacturing, because as these grooves deforms plastically, even if the tolerances on the manufacturing of the ball heads and the stem is not compatible, it deforms and it's still fit. If you have the smooth surface, like some American company used to promote in the past, if you have a mismatch on the tolerance of manufacturing, then you can have a big catastrophe, because it's very difficult to have it tight together. So to answer now your questions, I still believe, yes, 1214 is the optimal. We had this issue, especially now coming with, we're speaking about fretting corrosion with the ball heads, with the torque. We know that when we had the 1416 was even better, but you have more limited with the possibility to have the neck length adaptation with what the question was before from Dr. Kiran, SML XL. The larger the diameter of the taper, the less possibility of movement inside the ball head you have to adapt that. So I think 1214 is the optimal, but you will never be able. We tried, Ceramtech tried to motivate some other customers to all go on 1214. Some, as you mentioned, want to keep it. But important is to know that even within the so-called 1214 denomination, they have slightly differences in the angle, in the length of the taper. So this also plays a role. That's why we clearly recommend to use always the ball head which fits to the same company. If you have, because we know we are not selling directly, we sell to the Pew, Zimmer, Biomet, with the same now, Stryker and so on. So if you have ball head from Stryker, use it with the stem of Stryker, because they can have some differences, especially with the V14 and the other sides.
But you have taper sleeves for all these tapers? Sleeves?
No, only for the 1214.
But there are some companies offering for V40 and 911. Do you have any idea about?
If the company who makes the V14 taper ask us to produce for them, we will do that. If they don't ask us, we will not do. We are just a supplier finally of all this company. And as you mentioned before, the BIOLOX option, we push to have the BIOLOX option everywhere because it's also a safety situation for the patient. We push that in India, but I can tell you that Merrill, to not mention, is very active to have it on the market. Actually, DePuy has it indirectly by the Delta Motion system. They had sleeves for the primary system, but they're not interested to promote that, especially because they stopped the Delta Motion worldwide. But you used to have the sleeve in India, but Merrill will come with the official system as I presented to you.
Yeah, because the length of the taper is the issue in a revision scenario, and in India, we are hampered by that lack of supply. Yeah.
But if I speak now from the legal perspective, we always say legally, every company says you can only combine the ball head from the company A with the stem from the company A. But in case of revision, it's different legally. In case of revision, anyway, you will do the best for the patient. So you can adapt product from different companies. And you have to value what is more critical for the patient. Typically, if I take the example of the stem, which is a defective taper, then you cannot use a ceramic. You have to ask yourself, what is more critical? If I try to extract the stem, it's maybe more risky for the patient than to keep the stem and put a BIOLOX ball head primary, because you don't have the option system, on what you defined now, slightly damaged taper. And then you say, okay, I decide that that's the best for the patient. And nobody legally, again, just legally, nobody can sue you on that because you have done the best for the patient, because maybe revising a stem just to have the pristine taper to put a good taper is maybe too risky. And then you have to analyze, okay, I keep the stem. Now, should I use a cobalt chrome? But the cobalt chrome, if it's not tight, may have a higher risk of fretting and corrosion than the ceramic. So that's something you have to put in your consideration as a surgeon vis-a-vis the patient. But of course, if you have the BIOLOX option system, then you have more freedom with this choice.
Martin, I just recall the conversation which I had over a couple of beers at Agra with you.
Yeah.
And that was about the locking mechanism on the acetabular side. The line, you remember one company having a very different locking mechanism than the rest of them. Could you highlight that for the audience, please? Because the liner tends to fracture much more on that one specific system.
Okay, we speak about the angle.
Yes, if you could, see the audience is not very familiar with that. If you could just explain.
The same as with the taper 1214, Ceramtech also tried to motivate the customer to have an optimal taper angle for the acetabular for the liners, and he defined it was 18 degree. Why 18 degree? Because it's a compromise between the easiness to put the liner inside the shell and the strength to extract it again. And that's nothing else than the pure Morse taper concept. The tighter the angle, the more difficult it is put, but the more strong it is. So it's difficult to disassemble if you have a Morse tape, which is very, what do you call that? Straight in the angles. So we have, Samtech has done an optimize. If it's too open, it's very easy to put the liner, but the liner will never hold, it will easy to go out. So 18 degree was the best. Now your question, Narinder, some company decided they have a better idea. They make it more vertical. Instead of 18 degree, they have 10 degree. Because they believe once the liner is inside, it's more tight, is better, which is true. But the problem is the difficulty to put the liner correctly. And then you have this waggling effect. And if the liner is not, we always recommend once you have the liner to put the fingers around to make sure it's flush and then to impact. But if it's not nicely inside, it's more difficult. Then it's tilted, and this case comes to the higher rate of fractures. So now it's difficult for me. You claim it's more fractures. I cannot say anything about that. I can just speak.
I'll say the name also. It's basically the Pinnacle Cup, which has had these problems.
Which is our biggest customer. So I can answer you as a consultant. Scientifically, what's the difference on that stuff?
Actually,
if it's more, the angles like that is more difficult to put, and then if it's not put correctly, and especially with minimal invasive technique, it's more difficult to judge that. You may increase the risk of fracture.
Yeah.
More technique dependent.
Yeah. So one technique which these days which they profess is that you line up the liner on one edge and then with your finger slightly tilt it into the taper. Earlier we were introducing it face-to-face parallel to go in as much as possible. But now it is advised that you just take it and you match one lip and then tilt the other lip in. So all these companies come up with their own techniques of inserting. And initially that vacuum cup that which used to be the liner holder, which was coming. Sometimes it is difficult using those holders to place these liners properly. And if it is not going into the right direction, they tend to get jammed. And before they get jammed, you should remove them and then reintroduce into the right direction. So
you must know the system you're using and the degree of the cup you're using. And always, as Martin said, using your digit to go around the rim
so holding
before
the liner
before you actually impact it is the key. Because once it is tilted, like Narendra showed that X-ray, then you're inviting early failure.
It's very important to impact also the liner. Some people believe it's just the ball head, but the liner is the same. Even the perceiving is that the liner is more fragile than the ball head. Also, you the statistic with the fracture rate, but scared to impact. It's important to impact because you had some case, and it was recently a Korean study. They just put the liner by hand like this and never impact it. And especially with the larger ball heads, and if you reposition and you make your range of motion testing in a patient and you pull on the leg to see if the leg length is correct, if it's nicely tight, by having the ball head and the liner together, there's a high suction forces because it's highly polished material. And if you pull on the leg, so the head comes here, you disassemble the liner out of the metallic shell and you release it and it comes tilted. And you think everything was okay because you have done your test with the finger, was nice, but by pulling on the leg and releasing it, you can tilt the liner, and then you finish the surgery, and then you look the X-ray post-surgery, and then you see the liner is tilted. You don't understand why. So it's important to impact correctly also the liner, to avoid this effect that comes out. You have to imagine it's very highly polished surface, and you have two highly polished surface. You just put a bit some fluid, which is the synovial fluid. You have a suction force strong, very strong. We do that now in some of our booths. We show that effect. You can really disassemble a liner out of the metallic shell just by pulling on the head with the suction force. It takes out the liner from the shell.
And it can sustain a good impact, a nice, good impaction on the acetabular shell.
It will
provided it is properly aligned.
Exactly. I just wanted to add that. Provided you have the test and you look, if it's tilted, then normally it's difficult, but that's the possible risk. We had 2 or 3 cases like that of have in vivo fracture during impaction.
Just one more comment on basically the wear on the femoral side. Martin, you were mentioning about the presence of fluid. Would you like to highlight about the presence of fluid like blood or even saline when you hammer the head onto the neck or onto the femoral component? That may lead to the fretting wear. You need to have the taper junction absolutely dry with no absolutely. That's something which all our audience which is logged in. the fairly high number of young surgeons there. They must remember that they need to dry that femoral component at the taper junction. Absolutely, not even saline needs to be there. They leave it on.
It has to be completely dry.
That's a very good point, Narinder, because we have done some testing about that to justify that and to impact. We realized that even some presence of liquid may reduce the resistance, fracture resistance of the ball head. Presence of bone is also critical, but most critical is you have a small scratch damage that can come during the surgery for an instrument. If you have a scratch, this is very critical because locally you have a very high stress, and ceramic does not like high stress because it works on compression and may fracture. So we always recommend to clean, to dry, and also to see if there's no defect, and then to put the ball head and to impact. And this is exactly the same for the liner. Even though it's more difficult, we are aware of that, it's more difficult to make it dry because it's from the position, is always fluid inside, especially if you have open holes for the screws. But really to dry it and to avoid to have any rest of bone and put it properly. I'm personally convinced if this is done properly, there is really no risk of fracture of the ceramic. Most of the analysis we done is, especially with the liners, which is a critical part, in about 80% of the fractures of the liner, we can demonstrate there was something in between the liner and the shell or malposition of the liner.
Absolutely. So that's a good point, Narinder and Martin, that even a fat globule or even blood or a small drop of blood, you have to be, very meticulous about it. And many people have techniques to do that. So once you use saline to lavage it, you can use the 3 swab technique. So one large swab, another swab, and a small swab, so that you are 100% sure that circumferentially there is nothing on the taper and it is completely dry before you impact the, freshly opened ceramic head inside. So that's pretty important.
I'm aware that it takes more time for you guys in the OR during this moment when you position the ball head or the liner than maybe if you have a cobalt chrome or a normal polyethylene liner. But I can guarantee you this 1 minute more, I don't think it's more than that, to make proper to clean and you impact the liner properly, you can sleep quietly after. You don't have to worry about your patient.
There are a few questions to Dr. Narinder. He had given an excellent talk on the bearing surfaces. So I wanted to know what is your opinion about the highly cross-linked poly and each company's definition of it. Now somebody says 3 megarad, some 7, some 10. So the definition of highly cross-linked is so varied that if you try to cross-question the company that your 3 or 4 megarad, is it intermediately linked or highly cross-linked? So is there any definition like that based on the megarad exposure for the cross-linking? And what should we look at within highly cross-linked or intermediately cross-linked or so regular poly? So how do you?
Basically, the level of radiation to which it is exposed, anything less than 5 megarad is moderately cross-linked. And it varies between 5 to 10. If you go above 10, the poly is going to become brittle. So don't use that. Somewhere between 5 to 10 megarad radiation exposure will be the highly cross-linked version. But that varies. Basically, everyone has got their patented technique. And with addition of vitamin E, which is basically the oxygen scavenger there, I think the poly between 5 and 10 will be fine. But anything less than 5 is moderately cross-linked. I think you're referring to the marathon poly from Dipio.
Yeah.
So marathon is moderately. Marathon, they got their XLP range.
That's 4 megarad also.
I think they call their highly cross-linked.
They have Altrex now. They have an Altrex.
Now they have an Altrex cross-linked one. So marathon is moderately cross-linked. Yeah. So I think that's the only company I'm familiar with which has moderately cross-linked. Rest all of them highly cross-linked.
But the amount of radiation, as you said, 5 to 10, some also go up to 15.
Yes.
And some do multiple radiations, multiple times they radiate the poly.
That's the second generation cross-linking, which I did not explain in detail, that you do one exposure and then you do a submelt, what cell process of annealing. You subject the poly to heat up to a sub-melting point temperature, and then again exposed to radiation. So that process of annealing, radiation, annealing and radiation, that is supposed to increase the strength of the poly.
So all the major companies have got their own polys, which are so-called highly cross-linked polys, where I think the key factor is the radiation dose. And
the annealing process as well.
And the annealing process. And some are compression, while some are completely extruded. So you need to know.
Between that, I think you're referring to the compression molded and the ram extruded polys.
Yes.
It is proven beyond doubt that the compression molded polys are definitely much better. But
so that's not
people will not provide it to you because the cost of producing it is almost double that of ram extruded poly.
No, but does that is a process of manufacturing the poly. It has got nothing to do with cross-linking.
That improves the wear strength, the compression.
Yeah. So that is the compression molding and ram extrusion is not to do with cross-linking.
No, it is to orient the fibers of the poly.
So they also affect the cross-linking?
The radiation affects the cross-linking.
The direct compression and ram extrusion, is there a difference in cross-linking? Martin has some views on it.
Maybe Martin can enlighten us.
Yes.
Yeah, because
he's going to talk only about ceramic.
You're going to talk.
Yeah, I used to do that study a long time ago. That's a good question, but I think not, because you arrive to the remelting stage, so it does not have an impact after anymore if it's direct molding or ram extrusion. Maybe you keep some of the orientation, as you say, of the polyethylene chain, but at the end, the dosage you put, it's what you get out on the cross-linking effect. Okay. And these multiple cross-linking that we mentioned before, that was a multiple sterilization, actually, 2.5 kilogray, and they do that several times, but they never did go above the 10. 10 is the limit, as Narinder said before. Above 10, if you see a company selling something, you mentioned 15, I don't know who is doing that. It will fracture immediately. 10 is really the limit. There was
the maximum.
The maximum to be used clinically. There was some study going more, and they see the higher you go, the lower the wear rate, but the higher the mechanical
failure,
diminution of the mechanical resistance.
So just one more question to Narinder and Martin. So where does the vitamin E figure in this? It is to decrease the oxidation, and once oxidation is less, what kind of wear it protects? Does it only affect the fatigue failure, or it also changes the abrasive and adhesive wear?
See, once the poly is implanted, even still there is potential for oxidation of the poly. So vitamin E is going to extend the life of the poly by acting in vivo scavenger for all the free radicals. That's how it extends the life of the poly.
So all wears decrease.
Pardon?
So it controls all kind of wears, the fatigue strength and wear both, or it just
improves the
fatigue.
Just the fatigue.
So vitamin E cannot be substituted for cross-linking.
Oh, definitely. Vitamin E is available only in cross-link poly, not in the standard ultra-high molecular poly, where it can be added in that process only, in that manufacturing process only.
But it is not helping in that way. It is changing the fatigue characteristics of the poly, not the abrasive or adhesive wear.
Yeah, only the strength of the poly. So the rim fractures which were seen in the non-vitamin E polys are less with the vitamin E polys. So it increases
Martin,
strength.
You have something to say?
It just stabilizes, as you said, the oxidation, the degradation of the polyethylene. Polyethylene degrades if you have oxygen coming on the free radicals, and then makes it brittle. So these remaining free radicals are filled now with the vitamin E, which are not reacting with oxygen. So that's the role of the vitamin E, to avoid in vivo, because you are in contact with fluid with a lot of oxygen, to degrade with time. But the vitamin E has no effect on the wear resistance of the polyethylene. It's the same with or without vitamin E. It's just prolongating the life shell of the polyethylene to avoid.
So do you think with vitamin E, the cross-linking you can, or radiation dose can be increased? Because it is improving the fatigue strength, the E, and cross-linking is decreasing
the vitamin E just scavenge the free radicals.
That's it. Yeah.
If you increase the cross-linking, you have more cross-linking, you have more structure. That makes it brittle. And the vitamin E will not change that. Vitamin E will just go where is the open radicals. So you cannot stabilize more with the cross-linking. You will still have the brittle polyethylene with the highly radiation doses. Vitamin E will not help for that.
Okay. Narendra, are you there? Narendra has gone off, maybe because of the light. There is, okay, maybe Martin can answer. I wanted to ask about the locking mechanism of the liners. Now, this is not, I'm not talking right now about the ceramic liner. So would you like to discuss the poly liner? Because Narendra is offline, I think.
So I just try to share what I know, yeah.
So yeah, so I just wanted to know that we all the companies have gradually moved on to the taper lock, a taper design liner. The locking mechanism is a taper lock of the poly. Whereas some had, like the Biomat, even originally Zimmer had the ring lock. And there are a few other companies who had the ring lock. So it was purely for the user convenience that the taper lock came in and easy interchangeability of inventory going on to the ceramics, or it was that there were issues to be solved with the ring lock?
The idea is to reduce, you have to see the company that are making business. The idea is to reduce the inventory. So the optimal is to have one cup design which allows a lot of pairing surfaces, polyethylene, ceramic, and also metal on metal. There are some who claim they are able to do that. Metal on metal we forget now, but in principle it was the same concept as this conical fixation. So most of them have this conical fixation with the angle defined by initially by Ceramtech is 18 degrees to have a good connection. But then we need to have some ring inside to click the polyethylene to avoid it comes out again. And some has what we call that's a French word, marguerite. This small structure outside to avoid the rotation of the polyethylene. Okay. The daisy, we see in French it's called the daisy design, to avoid the rotation of the polyethylene. But if you want to optimize a cup system for the polyethylene, then you need to have an hemispherical reround. So you have the same thickness of the polyethylene all around the cup. And then it's the best for the high cross polyethylene. But in this design of the cup, you cannot put a ceramic shell.
Mm-hmm. So what are your thoughts on the Finsbury cup, Martin? Which was, the ceramic, which was a thin ceramic, flush with a solid shell.
Motion.
The delta motion, what you speak about, delta motion. Yeah.
Yes. So that worked very well in literature and also clinically in vivo. So what are your thoughts about having such a system where that ceramic is married perfectly to the shell and allowing you larger diameters?
That's an ideal concept. When it was developed by Finsbury at that time, the idea was, it was at the trend where the larger the head, the better, as we discussed before.
Yes.
So the idea was to optimize the thickness of the shell to have larger head.
Yes.
And by having this direct fixation between the titanium outer shell and the ceramic liners in the manufacturing process allows you to go to larger heads. Heads were going up to 48 millimeter, and it was just 5 millimeter thick. So you have a 58 cup, which allows you to have a 48 ball head. That's very good. The reason I think why DePuy stopped to do that, because this concept of having always the larger head is disappeared, as we discussed before, with the stability of the dislocation. So this came back in the trend, also due to the fretting corrosion, and then comes to the sizes, which is no more so interesting for American market. So the delta motion, to my opinion, was never a big success for DePuy in America. So, and often, like American companies are, if it's not working in the home market, it's not good for the rest of the world. But I discussed a lot with Dr. Bose about that, and a lot of other surgeons using the Delta motion. It's a perfect system, especially in countries in Asia and also
The
India,
smaller
where the
bones.
population is smaller people, smaller bones,
Yes.
because you can have now a 46 cup in a female patient and a 36 head, which stabilize very good the risk of dislocation, especially with the way of living that you have in India. To my opinion, the Delta motion for the Indian market, as well as for the small country, for small people
Asian
market, it was optimal, very good, much better than as it was developed initially. But again, these decisions to withdraw from the market does not come from Ceramtech, the manufacturer of the ceramic, but from the customer debut, which from the worldwide point of view was not interesting for them.
Yeah, because as you said, I mean, I have used it in my population here in India, and it certainly helped a lot. You know, in smaller bones, I could get away with a larger head, and had no risk of the fretting corrosion between the stem and the head, because I couldn't go too large anyway in a small bone. So,
but anyway, again, you will lose anyway ceramic ball head, which, as I tried to mention to show before, the loss of the material, if you have fretting corrosion, does not come from the ball head, but from the taper of the stem.
correct. Yes.
So even having a 36, even of let's say 38 or 40 millimeter ball head ceramic, it's not so risky from a fretting corrosion point of view.
Yes.
But you give a lot for your patient from the stability of the hip. And to my knowledge, this design that never had any fracture.
Yeah.
Yes, because it was already embedded from the company.
It's embedded. There's no risk of malpositioning of the liners. It's just a bit complicated to use, to impact with this mechanism.
Yeah. So yes.
But
so the point was the handling issues were there, and the population in which we were trying to use those delta motions, or we were using, were these small ladies with arthritis, or even in fracture cases. In fact, we were preferring it for fracture cases where we wanted to optimize the head size. But the issue was that the cup, being monoblock, was stiffer, insertion was an issue, and no way of getting a screw in. So these issues were still there. So although it was a very good solution for smaller hips, but handling of the cup and getting a good fixation was not always.
You mentioned one point which is also important. If you consider worldwide market, the fact that you cannot have screws eliminate a lot of markets. If you speak about just for example Argentina, you will never see any cup without a screw. It is in the philosophy any cup has to have a screw.
Mm-hmm.
Even sometimes just one, which to my opinion is, let's say, properly not ideal, but they always have a screw.
No, but I also used to feel, Martin, like that. But of late, there are retrieval studies which are showing that the maximum bone formation was at the neck of these screws. There was a time we switched to total solid cups, even in primary hips, and used to use all blocking caps for the holes with the good poly, not wearing backside wear going down, and the screws showing good outcomes in retrieval. In fact, when we go in for revision at times, the cup is good because between the neck of the screw and the cup, there is a lot of spot welds and bone ingrowth. So
my point was not about using the screw. My point was about using just one screw.
Okay.
To my opinion, it makes no sense to have just one screw. If you use screws, put at least two, so you have a rotational stability. That was more my point. Having screw, I have no issue with that.
Yeah. So when you were offline, Narendra, I asked Martin about the liner locking mechanism, and he had explained that taper lock we all are moving on to for the ease of inventory. I had asked him whether ring lock or taper lock, what is his reference? Any more
points remaining? Narendra?
I'm good.
I think we have covered everything. And
if any of the audience has
just one more issue, Martin and Narendra both can answer this. So when we discussed about ceramic and the polyliners, one thing which came out, which Narendra pointed out, that the options of the lip and the 4 mm plus offset, of course, that's the lateralized liners. these options, which at times we are able to use in a poly insert, the ceramic would not allow that. So are there any developments coming up, like maybe a thicker ceramic liner or something for lateralization, or that's not going to happen?
Yeah, very thank you for this question. Actually, we have that since now 2 years. In our portfolio, we have a ceramic liner with a lip and a slip like this, designed for the stability for the polyethylene. But again, we are just a supplier. We develop that, we test that, we guarantee it's safe. This is possible thanks to the BIOLOX Delta material. It was not possible with BIOLOX Forte. You have to see there's a lot of things that in the mind of the people we can do and not do in ceramic. And it was a lot of positive stuff we cannot do with alumina, but we can do now with the new ceramic. And it was a bit forgotten. So we have that. And again, we need to convince one of our customers, which is, again, Zimmer, DePuy, Merrill, to take it in the product portfolio. If they're willing to do that, we are more than happy to produce that for them and finally for you. So we have it. We have.
Yeah, because we would leave the liner option till the end. And if we need some adjustment in the liner, then we have to move on to poly in spite of wanting to use a ceramic. So having an option where we can control the coverage and maybe even lateralized liner would allow us to use a ceramic when the cup is not so perfectly positioned, or the native cup does not allow that kind of position.
I have one question to Martin. Martin, there was in between, about a decade ago, there was a development of Delta ceramic heads on metal liners, metal on ceramic. That somehow never picked up. Were there any concerns? I couldn't find any published studies on the longevity of that, survival. There was, I think, a company called Finsbury which was doing it, but I don't know what happened. Any clue about, because that's one bearing option which remains unexplored.
Yeah, actually, if you know the story behind that, it's only from DePuy, number one. Why? Because DePuy is the only company in America which has the two FDA approval, metal on metal and ceramic on ceramic. And their line was clear to say ceramic on ceramic and metal on metal. But since there were some fractures with the liners, he came to the idea of one of the surgeon, I don't know how to mention it, with the DePuy customer, to mix that. So he said, the problem is the ceramic liner, but not the head. So I keep the head and I will use now the metallic liner, which cannot fracture, and it's too hard on hard, should work. And he started to implant that without any rights to do that. It was not approved by DePuy. But since it was an important customer and there was some followers, so very quickly DePuy was in a urge to justify that it's possible to do. And a lot of testing has been done in Leeds University to demonstrate that it's actually not so bad to make this mixture. But actually, you don't solve any issue. The problem with the metal on metal was all this metallosis and the production of metal particles. So you reduce by half the production of the metal wear particle, which were coming from the ball heads, but not from the liner. So you still add some wear particle. But actually, effectively, you totally reduce the risk of fractures, because the ball head, it was Delta, the fracture rates, as I said before, is almost close to zero. So it's an alpha solution. But finally, I think DePuy could convince the surgeon that it was totally illegal from FDA point of view, because he was mixing two products which is not approved by DePuy. You have metal on one side, ceramic on one side, but mixing the two was not approved by DePuy.
But Zimmer had that product, and we have used it because Zimmer had that small head for metal on metal, and that liner could be married up with a ceramic head. Zimmer allowed it.
Yeah?
Yeah, this was that. We have used in 2005 to maybe 2009. That was.
I remember in one of the conferences they talked about using ceramic head and metal liner, but it fizzled off very quickly.
It went off.
I even read some publication which was really stupid to have the ceramic liner and the metallic head. That makes absolutely no sense.
Yes.
No, but metal liner and ceramic head we have used.
Okay, with Zimmer, from Zimmer. Okay.
Zimmer, yes.
With the Metasul, yes. With the Metasul.
Metasul, yes. So, yes, yeah. They allowed it. In fact, they asked us what option you want. ceramic or ceramic metal. So
Okay.
what was not FDA approved for DEPU, Zimmer has had that in market for a brief time period of time.
Maybe
Yeah,
they
but-
just told you can do it. They didn't show you a FDA approval for the combination.
No, they didn't have a FDA, but this is maybe in European market. It came out of the European market.
Yeah, they don't need FDA approval. They need a CE marking with the same situation. You have CE marking from one system, CE marking for the other one, and you're a customer from them, and you mix. And all these people, Zimmer tells, yes, you can do it. I'm sure they will delete all this email now. It was not.
So be careful about marrying unusual.
No, but
system.
metal and on ceramic was a concept for some time.
For some time, but then rapidly
a
put
few
under
years.
the blanket.
Not now, yes.
So I think we have covered nearly everything there is to cover on bearings and Trunnionosis. And I think the audience can definitely take home the message that you choose the appropriate surface and make sure that when you implant the bearing on the trunnion, it is absolutely clean and dry. And take your time. That extra 1 minute will make your hip last longer. I thank
And
Martin.
sleep better
Yes, absolutely.
for the surgeon.
Yeah, for joining us from Philippines, Dr. Narendra Kumar, Dr. Vikas, and I thank Dr. Ashok Sham. And with this, I conclude this webinar. Thank you very much.
Thank you very much.
Thank you, Kiran.
Thanks,
Thank you.
Madhu. Yeah.
Good evening, everyone.
Yes, thank you.